Auricular therapy has come a long way in the last 30 plus years in this country. Beginning in 1971, we started doing some work at 3-4 of our hospitals here in the Tulsa area. We began having study groups in some parts of Oklahoma, Texas, and around the country. And about 1973 and 4, I started spending some time on the West Coast for 3 and some up to almost 5 years. Terry Olson at UCLA did a lot of work, and I met him back in 1975. One of the books that he published is this, the second edition. We have some of the earlier work from UCLA School of Medicine back. It was published back in about 1970, in the mid-70s. 3 or 4 of the books from UCLA came out from 75 to 1980, where Terry Olson and Dick Cronin published some work that was published in the American Pain Society back in 1980, where 40 patients were draped with a sheet, came up with a 75% accuracy determining pathological problems in the body with that patient draped with a sheet. Back in the very beginning of 1971, one of the devices that we started working with first was the puntoscope. This is the puntoscope that had a potentiometer that you had to adjust sensitivity. And we had a little polarity switch that we had to put it, with the little dot you see there's a positive pole. To the left is the negative pole. The patient would hold this was the anode, and pull it back to diagnose and find and treat the point. We were using polarities back then. We had a bipolar electrode, a spring-loaded, that you see right here. Put it against this and you can see. They were both spring-loaded, and we looked at the differential measurement. But we had to adjust the potentiometer right here. We had to adjust the potentiometer, and we got Y's, and we were adjusting it all the way down as low as we could get it to 1 or 2 megohms. But it only delivered the device that looked like this, what was called the TheraPuncture, that would only deliver about 8, not generally more, and most of them not even 8 microamps of current. But this measured with 5 microamps of current. So what we're doing today exceeds the expectations that we got with this puntoscope back in, that was developed in the 60s, and we had some in this country back in 1969. A.E. Sola, that worked with our late Janet Travell, that worked with our late President Kennedy back in, she was his personal physician. But Sola started using the work back in 1973, according to his comments in 1973 in one of the meetings in San Francisco. Today, we look at treating points. We're treating a lot fewer points. Many times just 2 and 3 points does more than what we were getting with a dozen points. If we treat as many as 8 or 10 or 15 points, it's usually 1, 2, or 3 of those that do 80, 90% of our work. And what we're doing, this is one of the charts that we've used with all 3 dermal layers, which is a little complex because it's got so many points on it. But this is the musculoskeletal system just in the upper extremities. Here we have the shoulder, arm, the elbow, and look at where the shoulder is, right straight across from the concha ridge. Look where the elbow is on the inferior crus, here, straight across to the elbow. The wrist center in the triangular fossa straight across for the wrist, the hand and the fingers up in this area of the ear. Now, we started using what Dr. Nogé called the phases, phase 1, 2, and 3, back in the late 70s. And he was showing us some work in Montreal. I think his second trip that I was with Dr. Nogé was in the late 70s in Montreal. And some of the crude drawings he had where he drew the ear and would show some of the markings of second phase, upper extremity. Lower extremity was in the inferior concha. The spine was cervical here, thoracic, lumbar, sacrum. So now, in 1989, he reversed it where the cervical is here and the cervical is here on the trachea. That's the third phase, cervical, thoracic, lumbar, sacrum, you'll see in another chart. This is the lower extremity, the hip, the upper leg, the knee, the lower leg, and the ankle and the foot. The upper extremities, this is the second phase, lower extremity, and third phase, lower extremity. Here we are with the second phase only, both the spine, and this is what I use a lot today. It's a cervical, thoracic, lumbar, sacrum. That's after he flipped the spine. He reversed it in 1989 in the last writing we had from Dr. Nogé. This is where we had the cervical, thoracic, lumbar, and the sacrum was against the concha wall. So you'll see another chart where it shows a breakdown of where you see dimension on it. So we have, in the beginning, we had just the map of the body with the head at the bottom, the feet at the top, and the spine outlined the concha wall here. This was the cervical spine up to about the concha ridge. This was thoracic vertebra, and the L1 level is a little notch right about this level to L1 for the lumbar vertebra, and this was the sacrum extending all the way back underneath the ascending branch of the helix. In the late 70s, Dr. Nogé, we've been using the 3 dermal layers, what he calls the phases, and we were using what we call the auricular cardiac reflex, measuring pulse changes at the radial artery to verify some of the same points the punctuscope and the devices were picking up. And we were treating the TMJ and the headaches down here and the upper cervical headache here, but we got to use in the second phase, which goes across the concha ridge here, and the endodermal layer. And initially the cervical was this direction, thoracic and lumbar and sacrum against the concha wall. But in 1989, Dr. Nogé reversed the spine, and I feel comfortable in saying that it really enhanced our capabilities, because at the cervical level, you also may treat a sacrum like the Lovett brother effect. You can treat C1 and affect S5, C2 and affect S4. So we may be at the cervical level but relieve a sacrum problem, or vice versa. We may be at the sacrum and relieve a headache, as an example. So sometimes, many times, we get multiple results because of the way we look at the ear now, and we're more precise with our points. So this was the third phase vertebra, cervical here, thoracic, lumbar, and sacrum on the trachea. So this is exactly where, on the chart, the cervical, thoracic, lumbar, sacrum. This will get at least 70 to 80% to a degree out of pain just looking at this area alone, if you measure for that point. And we're measuring a little more precisely than we did back in the early stages in the 70s. Of course, the punctuscope was developed in the 60s. We started using it in the 70s, and quite a few in between with different devices that measured the same way. This shows the third phase. The spine is cervical, thoracic, lumbar, sacrum. This shows the third phase, upper extremity on the lobe here. And this shows the hip, the upper leg, the knee, lower leg, and the foot down in here. Of course, the foot extends and the toes extend on out in this area of the anatomy. This shows Dr. Nogé's first phase visceral. This is our workshop book that shows the morphological features of the ear. And if you're looking at taking the exam, we also have a certification program, Auricular Therapy Certification Institute, that was founded back in 1999 at the first international conference we had in the U.S. Terry Olson and I organized that conference, and this was the conference. It's at Tropicana in Las Vegas. This is some of the faculty that we found, that we had at this, 40 faculty from all over the world. This is Dr. Terry Olson. This is some doctors from China. This is Dr. Mary Glenn from France, Dr. Frank Barr from Germany, Dr. Ralph Allendale, he was in Florida at the time, Dr. Dvorkin from Israel, Dr. Cho from Korea. He was replaced by another doctor at the same facility that was an ophthalmologist, Dr. Bill Tiller, that was at Stanford. This is me, Jim. This is Dr. Murrah Columbia University that teaches some work in digital lowering technique. Dr. Lee Chung Wong and William Wong from, they're in Florida, but they're Chinese medical doctors. And Dr. Ong is past president of the Canadian Acupuncture Group, and Dr. Tony Lam, he's also from China. Dr. Ackerman, he's from the U.S., Dr. Fremelman from Israel, but we had doctors from all over the world at this conference. We had Dr. John Sonneridge that we were in China with back in 1982, Dr. Richard Yenny from Kansas City, and Dr. John Amaro that teaches a lot with the MRI, the electromagnetic imaging. We had 25 of the set 27 pre-conference workshops at that meeting. So what we're doing, to show you on an actual ear, what's an important area that we found in the very beginning where we were looking at these points, as I mentioned earlier, that the cervical was up here in the beginning, but this is the way we place them now. The little yellow one is at the cervical level. Between that and the red one is the cervical. Between the red and the white one, or yellow one, that's the thoracic vertebra. And between the yellow one and the blue one is the lumbar, and on up to the red one is the sacrum. The little white button you see there is 0 point. It should be right about in the center of the triangular fossa that you see here. It's about in the center of the triangular fossa. So we look straight across from the concha ridge here for the shoulder, straight across from the inferior crus for the elbow, the center of the triangular fossa to find the wrist. This is where you would treat the wrist. The yellow button you see here is the Shenmen point. The green one that you see here is autonomic that goes right back at the very end of the sacrum spine. The white one you see here is a 0 point. The thalamus, related to the cortex, is right in the center of the endotrachus, where the endotrachus meets the concha floor, as you see here. There's a point that this one is not in. It's right here that's called endocrine point for hormonal control. It's right there. That's the 5 major master points. So the back of the ear corresponding, if you were looking for the hip point, or pull this one out of 0 point and put it in the hip point right here, the motor neurons, as it comes out right back here, that's where you'd find the motor aspect of the hip joint. Here's where you'd find the shoulder, back of the ear. Just put your fingers like a C-clamp to find the back of the ear. You must keep the ear clean and dry. If you're not doing the auricular cardiac reflex, which is now termed the VAS, which I don't know too many that are really heavily successful with it, electrical diagnosis measuring in megohms is a good way to go. Is looking at just the greatest differential point. We measure that in megohms, which we'll show you just in a few moments. Terry Olson, back in 1975 is when I met Terry Olson. This is his 2nd edition, but about the 5th book he wrote. We have copies. In fact, a lot of these books, which we have about 7, I've got about 7 of his books. This one was the one I like. He has the 3rd edition out now that has foot and scalp acupuncture and acupuncture points in it. But this is spiral bound, and you can open it up to where you can print these and all the functional points and all the supplementary master points and all the primary major master points. But you can overdo. You can treat too many points. If you treat 8 or 10 to 15 points, it's usually 2 or 3 of them that do 90% of your work. This is what we didn't start with this at UCLA. UCLA started working with some of the earlier devices, but this one's been around a long time. It's called the Stimplex 400A that we measured in megohms, and we'll show a close-up of the controls a little later on some of the presentation. And it's measured in megohms, which we'll show you. In fact, we're looking at the tip and the ring. This is the positive, this is the negative outer ring over here. And put it on a meter. This can be positive or that can be negative. If it swings to the right on the meter, that's a negative point. If it swings to the left, that's a positive point, like you see here. That could be reverse of that. The patient holds an anode in the hand, and we use a bipolar spring-loaded electrode. The positive is spring-loaded, the tip and the ring is spring-loaded. And if, no matter what the resistance might be, if it's very conductive, it stays right in the center on the meter. If it's very conductive on the positive end and high resistance on the ring, that means that needle will swing to the left. If it's just the opposite of that, where the tip is more resistant and the outer ring is positive, it'll swing to the right and automatically give you a negative treatment, negative automatically. I've drawn a little diagram here. No matter what the resistance is, if the resistance is 8 megohms positive and 8 megohms resistant, that means the needle stays right in the center. If the resistance is 2 megohms positive, 2 megohms negative, it'll still stay right in the center. It's when the ring is resistant and the center tip is positive, it'll give you a 2 megohm rating. So if it's equal, it doesn't give you that. If, on the other hand, the center electrode is negative here, and the outer ring is, say, 7 or 8 megohms, it may give you a 3 or a 2 megohm reading, or even a 1 or a 0.1 megohm. The lower the reading on negative, or the lower the reading on the positive, is the point that's going to generally do 90% of your work. So that no matter how conductive both points are, or how resistant they are, if it's equal, it is not considered a point. And here we have the positive on the left, the negative on the right, and it's measured and scaled off for you in megohms, like you see here. Even the search current flowing at 1 microamp can be effective if it's the right point, even if it's not pulsating. But we have certain frequencies, like if we're dealing with musculoskeletal body, we treat that point at 10 hertz, the frequency. If we're dealing with addictions or the brain points, those are all treated at 80 hertz, 80 pulses per second. If you're dealing with visceral problems, it's all done at 5 hertz. If we turn this on, we see a needle swing up to the center, and we can tell that the little red light's on in the center indicating a positive, that we have the switch in the negative pole. We set it in the automatic pole, so if the reading goes to negative and we find a point in the negative, we push this button and the red light comes on, giving us an indication that we're treating from the ring positive to the center tip negative. So you're delivering a negative square wave. On the other hand, if the needle goes to the right, to the left, you see here, and we push the button to treat it, we're going to the left, the light doesn't come on, and we're treating with the positive. It's going from the ring negative to the tip positive. So this automatically, the term auto means automatic, treats with the polarity in which it picks it up. So the fact that by searching this with the spring compressed, not to the bottom of the spring, but about 10 to 20 to 30% or 50% would be okay. But the light pressure, since they're both spring-loaded, you want as light a pressure as possible. You want the ear very clean, removing all of the skin oil, all of the spray, everything from the ear to where you have no residue or moisture or hairspray or anything that will cause you to get a false indication, a false reading. Weak techniques work to a degree. Right point, it takes a lot less points. 80 to 90% of our effectiveness is generally from 1 to 2 to 3 of those points, and sometimes just 1. Many times 1 point will be effective better than a dozen points. So it didn't take a long time to pick up on that and learn that less is better, that the fewer points you treat, keeping this clean. And many times I've seen these electrodes come in to where we had hairspray, not hairspray, but necessarily dead skin and oils, and these were clogged up. that whoever was using it didn't know this had a center electrode in it. So you can see the tip here, which is spring-loaded. There we can see it. And oils and residue will get up in there and clog this up. So to pull this back and wipe it off between patients, ideally in front of the patient, because then they not only, and you don't tell them I'm cleaning your ear, tell them you're removing all of the oils and all the dead skin or anything residue that was left on there when you showered this morning, to make everything very smooth and very clean. And also the ear very tight. As an example, when we're working with the ear, you want the skin not to roll up like you see here. You want the skin to be loose like this. You have to use back pressure, and you have to press perpendicular. You want the probe as perpendicular as possible. And then when you find that needle, go over and move it very slowly. As you see the probe moving like this, that's about 10 times too fast. A movement that you hardly see move with the tight skin is the way you want it, and you want it perpendicular to the skin surface like so. You don't want it cocked at angles like this. You want it very perpendicular to the skin surface. You don't want the skin to move. You want it tight, and you want to glide it so slow that you hardly see it moving, and then you'll see that needle swing. See the needle swing over there to almost 1 megohm. Now this is on the body. You're going to find more electrical measurements in megohms on the ear, certainly, than you're on the body. This is not designed for the body. For the body, we use a monopolar. We use monopolar electrodes for the body. And we keep this probe perpendicular. We use 1 hertz as the universal frequency, which we rarely use anymore. It'll treat everything. 2.5 hertz is subtragus. 5 hertz is for visceral, for your internal organs. 10 hertz for all the musculoskeletal body. And no matter which dermal layer you're in, you still use 10 hertz. Use 20 hertz, that's the tragus. 40 hertz for the spinal cord. The spinal cord is from Darwin's tubercle. The tail of the helix is the spinal cord. This is the cervical spinal cord, this is the thoracic, this is lumbar, and this is the sacrum. We use the spinal cord for inflammatory conditions. We use the spinal cord if you have skin problems, like you have burns, psoriasis, herpes zoster, or acne, or any skin problem. We back it up with the spinal cord, and all skin problems are backed up according to the Chinese with the lung point and the kidney point, and urticaria. Urticaria is a skin condition itself, but that's support help for all your skin problems, whether it's a burn, psoriasis, herpes zoster, acne, poison oak, poison ivy, any sunburn. You can take 70–80% of the pain out of a sunburn, and half of the redness will leave in about 5 minutes. So it's pretty impressive for skin problems. For addiction problems, we back up. We have a nicotine point, which sounds like it'd be the primary target for smoking, but the lungs really are. Lung 1, which is Chinese, lung 2, which is both Chinese and French, for smoking. The mouth point, the palate point. The palate I find right about in the center on a straight line from the antitragus, and about halfway between the tip of the antitragus to the tip of the lobe. It's halfway between. So draw an X here, and here the palate point is right there. So look at all of the landmarks to find these points. Like here's the brain point, which is sub-antitragus. Sometimes that's used in your chronic smokers. So the brain point, the lung and kidneys are primary targets for smokers. The Shinmen point, the 0 point, the palate point, and the nicotine point. So when we're scanning and looking for a point, we pay attention to the tone changes. And you can hear the tone change as I'll go up to find a point at maybe Shinmen level, which usually comes in at about 1 megohm. There we are right there. Push the button and treat it. And we can tell the frequency is off. That's what it should sound like at 10 hertz, as you hear there now. And it beeps every 8 seconds. 7 to 10 seconds is influencing a point. Beyond 16 is sedation, but you don't stop at 16. For 2 or 3 years we did. We treated a lot more points. we treated 3 to 4 to 5 to 10 times as many points, but we found out in a Vienna meeting with Dr. Nogé that fewer points you treat, the better. Adequately treated the points in the back of the ear having to do with the motor neurons. We went to the back of the ear for motor neurons, for joint problems, and your backs, your shoulders, your necks, even including some of your headaches. The back of the points even work better than some of the sensory points. The anterior portion of the ear is sensory. The back of the ear is motor. Look at the maps well, and look at the readings you get, and you may check phase 1 and not find a point, but going down to the endodermal layer, which is in phase 2 in the concha, and now you can go back and recheck in the lumbar if it's a back problem, and you'll find a point that didn't exist to begin with, but you're removing blockages. And blockages, we'll talk about toxicity, we'll talk about toxic scars, and we'll talk about amalgam blockages, and we'll talk about laterality and oscillation in another video and another DVD. But if you have a blockage, well, sometimes we have to worry about removing that blockage in order to get the ultimate in success. But the power auriculotherapy has, many times we're going around those blockages because of looking at the endodermal and ectodermal layer. The ectodermal is the superficial layer. The mesodermal is the middle layer. That's where we find the musculoskeletal body in the first phase. And the endodermal is the deep layer. That's where we find the musculoskeletal body in the second phase. Like that's in the concha, and that's what I use a lot. Some feel they get better results initially on most of them at this third phase, ectodermal layer, but I found overall that the endodermal is by far is where sometimes I start first. Now if you're looking at taking an exam, nothing about the phases is in that. And if you look at Dr. Beata Stittmacher's work, she doesn't have the phases, but they do have, which will come in a different, we do have the meridians in the ear, and we have them localized, and it's on our chart that we see, like you see with this chart here. We have the meridians, all of the meridians are also can be treated through the ear. Here's a chart, here's one that I put together about what's off a little. This red one needs to come down a little because this is where you find the cervical, the red one here. This is the thoracic, this is lumbar, and this is sacrum. That area alone, if you measure properly and get down to 2 or 1 megohm on your points, will generally get you 7 out of 10 out of pain in less than a couple of minutes. And rarely you have to go over to the ectodermal layer. This is cervical, thoracic, lumbar, and sacrum, and the ectodermal layer. This is cervical here. This is, which is where we left off. There should be one down here that shows the cervical. This is thoracic. Between here and here, this is where C7, T1 connect, is right about this level. This is thoracic, this is lumbar, and this is sacrum. Using the back of the ear for the motor neurons. This alone will help you on 7 out of 10 of your pain patients, just looking at this one chart here. Adding the Shinmen point, autonomic point, the 0 point, which is right about there, the thalamus, which is behind, right, if you put a needle right there all the way through to where the concha floor meets the subantetragus, and the endocrine for hormonal control here. So the 1, 2, 3, 4, and 5 points for circulatory is autonomic point. That's right at the end of the sacrum spine. That's where you find the autonomic point for a circulatory problem. Terry Olson's book is indexed very well, and you could buy a dozen books and probably not invest your money more wisely than just getting Terry Olson's book. You could benefit greatly because the way it's indexed, you can find all the points and the function of all of the primary points and all of the secondary and functional points and all the points you treat. The problem I see at times is you're looking at several protocols and you're only looking at 2 or 3 years to pick up all those points. What we have done is taken all of these points and put it in a protocol book of 217 protocols. That's table of contents, the category, and in the back of the book for 217 protocols is an index of all of those protocols. And what we've done is putting 9 per page because of weight and printing, and these are available in color at Electrotherapy Association. And I'm the one that put these protocols together. 90+% of them do not have the second and third phase points, nor does any of the other books that we have. But we do show all of the second and third phase points, like you see here in this book, Auricular Therapy, the Ultimate for Pain Management. This cover was done in Albuquerque, New Mexico, an American Academy of Pain Management meeting, and I observed this thermography, sat with a computer. I said, what's the range of motion? About 25 to 30%. I commented to the doctors, there was about 4 or 5 doctors observing, and this doctor sitting with the thermography on him, and the fellow taking the thermography. I said, well, we can change all of that very quickly. So well, how are we going to do that? So we went down and used auricular therapy on him for about less than 5 minutes, brought him back, and set with the computer the same setting. This is what it looked like on the thermography, and the fellow taking it says, this isn't the same individual. He said, well, yes, I am, but look at this, like full range of motion. That arm just went up. He finally did get the arm down, by the way. So we have, when we're looking at these points, like it's an area, like where is best suited if we're working with TMJ problems. Sometimes it's at the cervical, the restricted area at the cervical level, or maybe it's, and I've had a lot of them helped here. And also here on this, for the cervical, which is the third phase. I even treat a lot of them up here where we used to have the cervical up here, thoracic here, lumbar here, and sacrum here against the concha wall. But in 1989, when we got the last book that Dr. Nogé gave us, well, we're helping a lot of them here, and even some in here. But I'll still even sometimes go out here and search. We'll show you on another chart, if not on this DVD, because we let the body tell us where to go. The mapping is great to get us started and go to the right area, and you'll see here from some of the points, as an example like this, the liver and the bladder and the pancreas. Is it a point or is it an area? It's an area in which you search for that point. And it's really the same way here. Is it this shoulder point, the master shoulder, and the shoulder joint is down sometimes on the Chinese chart a little bit lower. That's this one over here. Here's the shoulder joint. Here's the shoulder. And this is Chinese, of course. I did this chart in the clip art. The clip art doesn't show it, as you'll see a little later. And on the next one I'll show you is another Chinese chart. I like the idea of the cervical, thoracic, the lumbar, and the sacrum, and they stopped the sacrum a little short. And actually, I didn't make normally the sacrum is up in here. I made a turn with it out of the clip art. I'll probably take that apart because this is where the Chinese would treat the sacrum right here, not down here. So that's the little difference, and I just didn't want to take the clip off apart. And it's like the lungs, the number 1 and the number 2 lung, with the heart right in the center of the inferior concha. The stomach is right on the concha ridge. The liver's on the concha ridge. The spleen is in the inferior concha, and Nogé's spleen is in the superior concha. So this shows the small and large intestine. It shows the kidney, where Dr. Nogé considers the kidney and the heart to be derived from mesodermal tissue. So Dr. Nogé puts the kidney right underneath the ascending branches of the internal helix right here. It's back underneath, just below the Nogé lower extremity. The difference where the Chinese place the lower extremity is on the superior crus, where the Chinese place the lower extremity here in the center of the triangular fossa. The shoulder and the arm, the elbow, almost identical to where Dr. Nogé places it. And in the second phase, before we flip the spine, Dr. Nogé placed the heart exactly where the Chinese placed the heart in the inferior concha here. So really there's a lot of similarity except for just the heart and the kidney from the Nogé internal organs and the Chinese. And I think the Chinese, even in China, Dr. Sunderledge was with us. We were in China in '82. I've only been to China one time. I've been to Spain, I've been to Russia, we've done seminar work in Spain. But in France, Dr. Nogé is, in my opinion, the real father of auricular therapy. Even though he, Dr. Bourdieu, and Dr. Frank Barr disagreed with some of the phase work that he did, but I do believe there's more than just one map. And you'll see, not on this DVD, but where the meridians are in the way Dr. Frank Barr uses the meridians. He also has a book on the chakras, which will probably get it printed in English. He's given us our permission to do that. So as far as all of the booklet that has 217 protocols in it, all of those came from this size ear. We've reduced them somewhat with this, like headaches and tinnitus, smoking withdrawal, and drug addiction. Tinnitus is one of the major problems in medicine, and we've got a pretty good percentage going into the auditory meatus. Rarely do we have to use this many points in the ear. In fact, I probably used it maybe a dozen times in my 30 years of experience with auricular therapy, but I probably used the auditory meatus from maybe 2,500 to 3,500 times. And the auditory line, possibly 10% of that. Auditory line, remember the jaw, the mastoid bone, and the inner ear. So with hearing loss and tinnitus is a major medical problem. Also, acne is a major problem, which is pretty effective according to some of the research that was done at the University of Nevada with Dr. Denise McKee. So the smoking problem that I would venture to say there's into the one clinic is treating about 50 a day, and they've been using it for probably 15 years at 50 a day. That's quite a few patients. Some are claiming into the thousands of patients. One clinic in Fort Myers, Florida, that one of our board members, Dr. Mary Bonnet, they were claiming 10 to 12,000 like 15 years ago. And they're doing it day by day since then. Drug addiction and alcoholism, headaches, that's just a few of the 200 and some protocols. This reminds us of the back of the ear of Dr. Nogé. And the one doctor that did these nice drawings was a doctor by the name of Dr. Bourdieu from Paris, France. This is one of his 2 or 3 books that he's written. And this very chart that you see right there, I believe is right here, yeah. Right out of the textbook. And this is a little diagram that about the point. This is what a point you'd visualize it looking like. This you see right here would be the high resistance. This represents conductive tissue. And this would be the ring on your bipolar stimulator. This would be the tip, which is your active electrode. If this would be positive, this would be negative, which would be measured on your instrument here to the left. If it happened to be the reverse of that, the center would be resistant, the outer ring would be conductive. That's when your needle would go to the right, over here, to the right side. And it's measured in megohms, 9, 8, 7, 6, 5, 4, 3, 2, 1. You don't want to pay any attention to the 9s, 8s, 7, and 6, and 5s, and 4s, and 3s. Try to get it to 2, or better still, get it to 1, or even 0.1, the lower the resistance. This would be where both was high resistance, the needle would stay right in the center. Or if they were both very conductive, like you just had, if both of them were very, so it's not a matter of how high the resistance or how low the resistance, it's how it varies from high to low, as I showed you on that diagram that earlier. So it's no matter what the resistance is, if it's the same, very conductive or very resistant, it's equal. So that needle would stay right in the center on your meter. It's when the outer ring is more resistance and the center is conductive, does it go to the left and give you a positive reading. And those are the points that's going to be effective for you. And you can tell that by the way the patient responds. You can't measure them and go back and remeasure them because sometimes they'll even be more, but you can release it. You'll neutralize the tissue right under the point, okay, but you'll still be able to find the point. Only when the condition is healing and when the patient is responding to the therapy will they be the same. That way you won't find the points. So, as I say, these protocols are mostly all first phase points. And there's many times that there's points that haven't been worked out. It's just like there's a condition, xerostomia. That's when we have extremely dry mouth problems. It's working about 90+% on xerostomia and better. And we have material on that from some research that was done at the Cancer Treatment Centers of America. So that'll be explained further on some of our videos. But many of the conditions that we see from our fibromyalgia, our neuropathies, our headaches are a breeze. My neurologist that I'm seeing is using it for headaches now. His therapist that I'm also using is a physical therapist due to a fall I had about 3 years ago on the ice. So I'm seeing a neurologist for my memory and also my stability problem, and I'm doing some exercises with my therapist. So Keith Koo, a physical therapist that I'm going to, came, and now I said, what are you using it on, Keith? He said, just about everything I see I'm using some auriculotherapy on. So it does have some merit in many chronic and situations that create problems for us. Now, to give you a little bit more information about these points, it's not where the chart shows them to be. It's just like this. This shows an area of the lungs that we treat for smokers. Now, this lung is a little bit low, in my opinion. I think the lung point that normally we're looking for is up a little higher, where this shows an eye point. Well, many of our charts show the eye point to be a little further over. Here, the mouth is placed about right. Here we have the stomach that's hardly on the concha ridge. The concha ridge doesn't come quite as low, and it's kind of small. It's just like the shoulder joint, and the shoulder itself is a little bit lower than the concha ridge. So if this be, and in fact it just shows pictures, like the one that I drew, where I had the cervical spine here and the thoracic here, the lumbar here, and failed to curve it up like for the sacrum. The sacrum, the Chinese would place right up in this area of the ear. But this pretty well shows right across from the concha ridge the shoulder. This shows in the inferior crus the elbow. The center of the triangular fossa, which isn't as clearly defined here. It's not as clear on this chart. But the center of it would be where you'd find the wrist. So as we talked earlier, the upper extremity is almost identical to where Dr. Nogr2 shows it to be. Where it differs is in the triangular fossa, where the Chinese show the uterus to be in the triangular fossa, where Nogr2 puts the lower extremities. And the lower extremities for the Chinese are on the superior crus here. But it's an area, like where would you treat the stomach? From here to here, you could place a dozen or 2 dozen points in the stomach. Like some of these points that Dr. Nogr2 gave us, like you see here, this is all the first phase localizations. Well, here's the stomach with Nogr2. Here's the thymus. Here's the liver. Here's the rib cage. It shows an area. And like this is the wrist. Here's the hand. So here's the fingers from here to here. The thumb tip would be more in here, the little finger would be more over here. So you're looking from the little finger to the thumb tip, this much of an area. So you've got to go to the area where you expect it to be. This shows a point that I use. I start right here. Just a few months ago, I probably treated at trade shows 70 to 80%, if not 90%. I would just as soon treat the patient without knowing where their complaint is. Usually within the first 1 and 2 points, they're out of pain. Well, I cheat a little. I watch body movement, of course. But I start right here. It's a cervical level, thoracic, lumbar, and sacrum. So you're going to help because of all of the nerve fibers that come off the spinal cord. Here's the spine, first phase. This is the spine, second phase. Here's the spine, the third phase. So if you're looking for, if you don't get a point here, I'll immediately jump over here, or go to the first phase, one or the other, but usually it's the third phase, which is the ectodermal layer, and find a point there. Then if you get somewhat of a change and find a good point, say it's a 2 megom point, you many times go back to the second phase and now find points that didn't exist on the first scan. Or if you scanned at the lumbar here and not find a point, and you remove a blockage here, now you can go back and not only find the point, but the point will work, or otherwise you wouldn't even find it. Don't attempt to be real successful unless you're finding a good point. And getting that potentiometer out of the way, and most of the devices have that, by removing the polarity switch, and let it do automatically, this one right here, by removing the potentiometer and measure every magohm measurement, whether it's 9 magohms in our center and no magohm differential at all. it speeds things up for us considerably because we don't have all the time element looking for the primary target that we want to treat that's going to be most effective for us. So these were great, but we had to send about 20–30% of them back within the first 30 to 60 days, and there's 2–4 to get them back in from France. Sadat made these. That's Dr. Paul Noget's son, John Noget. And so this is what we do. We look at this chart here. You would use a lot with your backs, your headaches, and extremities and all, because the postganglionic nerve fibers is in the wall here. That's in the wall. This is the thoracic cut. This is the cervical cut. The vertebra would be right on the ridge. This is the transverse process, the post process. The disc is anterior toward the concha floor. The postganglionic nerve fibers are in the wall just below the disc. The muscles and tendons, the ligaments and muscles and tendons are out in this part of the anatomy, right out in here. This is the helix tail right here, as you see here. That's the helix tail. So generally you're going to find the points out in here in the musculoskeletal tissue. And this showed initially the rib cage was here before he flipped the spine. Now I consider this to be the rib cage up on this side. And when he flipped the spine, before he flipped the spine, the heart was exactly where the Chinese placed the heart, right in the center of the inferior concha. When he flipped the spine this way, this is the heart is in the superior concha. So this chart you would use a lot. This is a cutaway of the beginning of the lumbar. This is L1 level would be right about here at the L1. This is a cutaway of the lumbar region. And the sacrum is the diamond shape you see here, and this is a cutaway of the sacrum area. So you want your probe perpendicular, you want to find the greatest movement, whether negative or positive. You push the button and you treat it, and it beeps. The Simplex 400A beeps every 8 seconds. 2 of those beeps would sedate a point, 1 of them would tonify the point. But if you're on a point that's working, you may be on it 45 seconds, a minute and a half, as long as it continues to work. If the point seems to stall out and you're treating a back pain and it goes down 60%, which would drop it down from 10 to 0, being a 4, and it seems to stall out in 16 seconds, a point that would otherwise have been a 4 and still a 4. But if you measured that point at 1 megohms, give it the benefit of the doubt. If it's dropped from 10 to 4, that's 6 points down. Release the button, give it a couple of seconds, a count of 1, 2, push it again, stay on the same point, watch it. Many of them will accelerate and say, oh, what are you doing? And now I really feel the pain going. Sometimes you just giving it that little break and rest. Sometimes lets it go right on and work for you. So this is a chart that you could benefit a lot with not just your backs and upper thoracic problems and cervical problems and headaches, but many other joint problems. I was treating one of the head doctors in research at the Cancer Treatment Center. I didn't find a point till I got to the sacrum in the right ear. She said, now the pain's gone on my right side. Immediately, instead of searching the cervical on the left ear, I went to the left side. I went directly to the sacrum. In about 30 seconds, now my pain on my left side is gone. It wasn't the sacrum. It was her feet that were bothering her. So I treated a doctor at Malcolm Grow at Medical Center. She had an upper thoracic outlet syndrome. She had a headache, low back pain, radiating down into the left hip and the top of the left foot. Because of her headache, I started right here. I expected, because of her headache, to find a point there. I didn't find anything. I went to the thoracic because of her upper thoracic outlet syndrome. Nothing there. Lumbar because of her back pain. Nothing I found. The sacrum, I found a point that went over to 1 megohm negative. Within about 30 seconds, she said, I have no pain. My pain is gone. I said, how about your headache? It's gone. My headache is gone. How about the upper back? She said, it's gone too. What about your low back? It's gone. What about the radiating pain down the foot? It's gone too. I was telling 3 doctors about this at one of the meetings in Chicago, and I had them, all 3 of them, on the program to show them, and I said, watch me treat the next 3 or 4 patients. And the group of about 300 plus doctors, I said, we have 3 doctors that's never used this. You're not to divulge where your problem is. They've never used this at all, but they have been coached. Up in the left-hand corner, we have 3 doctors that's used this from 25 to 30 years. Down here with me, Dr. Steve Burns has used this almost a year now. So 7 of you, those that's brave, go up in the right-hand corner. They're waiting for you. When they were allowed no more than 2 points and no more than 2 minutes. 7 out of 7, only 2 of them took the second point. 3 of the doctors had never used the electrode at all. So this is a powerful area for you for a lot of your conditions right here at the cervical, thoracic, lumbar, sacrum. And as I already told you, a lot of these points, as you'll see, here, you're looking at quite an area. It's just like the stomach. The stomach in the second phase is almost 2 inches on the ascending branch of the helix. You have an area in which to search for these points. If you're working with musculoskeletal body, you're always at 10 hertz. Whether you're in the concha, whether you're on the tragus, or where you are, it's musculoskeletal. If you're working with TMJ problems or back pain, and I think even headaches, because most of your headaches are derived from stress-related problems, which is the cervical. You're going to get a lot of them at the cervical, whether you're in the third phase, second phase, or your first phase, or the back of the ear. Remember the back of the ear. We didn't start using it until almost 2.5, 3 years into the therapy. And most of that came from a Vienna meeting back in the early 70s, about 1974. So this is the 3 territories you will find to be very effective if you understand Dr. Nogr's theory. And one of the things that we must mention to you, some of the doctors and most are having more success quicker, because you still have, if you use the color filters, the red filter is a Kodak red filter signifying a problem in the first phase. The green filter would be the second phase, the blue filter would be the third phase. We also use chemical mediators in these filters, just like if we're looking for a scar blockage, we use a filter with scar tissue in it to tell if we have a toxic scar. You could probably treat a toxic scar in the ear quicker than you could search for it. So if you're suspicious, so look for scars, look for laterality, look for laterality, which we'll go through some of the procedures on a future DVD for you. But this is the little magnetic, this shows the gold and silver hammer, this shows the magnetic hammer, this shows the black and white hammer, and the 3-volt hammer. So you have to turn the hammer in the direction, if you're looking for a positive or a negative point, whereas electrically will tell us whether we have a positive or negative point. If we're using ion pellets, or we have the ion, or we have the ASPs, the semi-permanent needles, we influence a point with gold, we sedate a point with silver. Positive, negative is alternating currents is stainless. So we use filters if we're using the VAS. Because of the complications and time element that it takes, when you're treating patients, time is of essence, and certainly results are of essence. And many that are using, some of these are just using first phase, but I think those that are understanding Dr. Nogr's theory on this are outperforming some of them, and certainly they're doing it pretty quickly. So this is a little supplement book to your workshop book. So Terry Olson's manual that we talked about, you could buy 100 books, and you just don't need that many. You don't need to spend thousands of dollars for books when they're not needed that greatly. So Electrotherapy Association is based in Tulsa, Oklahoma. Our website is electrotherapy.com. We also have a website, Electromedical Inc., electromedicalinc.com. My email is jim@electrotherapy.com. You can reach us by info@electrotherapy.com or donovan@electrotherapy.com. And ACI, Auriculotherapy Certification Institute, is auriculotherapy.com and .org and .net. We have 3 websites, Auriculotherapy. So we have a certification program. It requires a pre-approved seminar that you attend to set for an exam. 75 questions. You can miss 17 and still pass. You miss 18 and you flunk. But we're beginning a workshop program, hopefully nationwide. They're all not going to click because of time and because of the heavy practice and being able to take the time to support them. But I think of all the many doctors that's using it across this nation and around this world, to get together and compare notes. Some are not having success with smokers. Well, they'll find out how. Some are not having success with maybe their skin problems, psoriasis, herpes zoster, acne. Denise McKee, I think I mentioned, did a study that turned out beautifully at the University of Nevada. The smokers that you treat, some are adding maybe some vitamin C. Since we deplete the body in vitamin C, which when we're a smoker, by adding 500 milligrams every hour for the first 8 hours, and about 2,000 every day for the next 30 to 60, if not 90 days, can be support for you. So, what I like to see is enough fee to where you can afford to treat them 2 or 3 times if they need be. But most of them, if you have them breathe prior to your treatment, they can breathe from 30 to 50% more capacity after you treat them, the lungs. So my thoughts are charge them enough money that you can afford to treat them 3 or 4 times. If you've got to have the cigarette, come in and we'll treat you, and that's included in the fee I'm going to charge you. But since they're having to pay 2 or 3, maybe a couple $100 a month for cigarettes, is the price of cigarettes, a $200 fee for as many as they need is a pretty good fee. And it sounds cheaper than even $50 per treatment, because they don't know whether they're going to need 2 treatments, 5 treatments, or a dozen. But 7 out of 10 should only need 1, if not 8 out of 10. Many of them are claiming 80 to 85% with smoking problems. So anyway, look forward to seeing you at our seminars, our workshops. If we email you, look at the little form pertaining to our workshops. Give us some ideas and what you think about continued month-by-month workshops. And I think this will help get you new patients. We just treated day before yesterday, I treated 28 in the morning, and I think it was about 18 in the evening. Didn't leave the clinic until about 7 o'clock. And 2 or 3 weeks before that, I treated but 53 patients and 3 doctors in the one day. And that was from 8:30 until about 6:30 in the evening. So this doctor has not been doing auricular therapy, but we had treated the business manager, which you may see her comments on one of the clips we have. So we're doing some video work with some of the patients, and if you have a video camera, share it with us and help us with our workshops nationwide. Whether you're in Phoenix, Arizona, whether you're in New York City or Miami, Florida, or Puerto Rico, or wherever you might be, why, get in touch with us and share information and fill out the little form that we might email you, and send us your email address. If we don't have your email address, send it to us, jim@electrotherapy.com, info@electrotherapy.com, or donovan@electrotherapy.com, and we'll see to it that I think we should have something going on every month. And I think you should have in your office or in your city a way where the doctors, your chronic patients, can come and get information and learn what auricular therapy has to offer. Many of those stubborn chronic patients that are difficult sometimes to handle, and auricular therapy, and sometimes just 1 or 2 or 3 points. And the fewer points you treat, like I said, if you're treating 10 to 15 points, it's usually 2 or 3 of them that do 80–90% of your work. Stay with those points. If the patient can sense when something's flowing, where they feel the pain leaving, where they feel that point is benefiting their complaint. So from headaches to back pain to sciatica to fibromyalgia, neuropathies, can you imagine a 30-year neuropathy, 2 treatments whether they need the second one or not? Pain was gone after 30 years of suffering, could hardly walk across the street, and his name is Mike Fawcett. And 6, 8, 10 years later, still no pain. Can you imagine corporal tunnel syndrome, numbness and pain for 10 years, 1.1 minute in the wrist area in the second phase, numbness and pain left, and I saw her again about 3 years later in Atlanta. The pain was still gone, and I talked with her doctor, probably talked to him 15 or 20, which she's married to, and the pain is still gone. She hadn't had the second point yet. So she's still working as a dental hygienist. One would assume that that would be right back within the next, certainly maybe 2 or 3 treatments to even help it, since it didn't come overnight. So your carpal tunnel syndrome problems are chronic, because they don't even know they have something coming on for many times a year or maybe 2 years or many months. It starts developing. And one would assume that it's going to take 3 or 4 treatments or 4 or 5 visits to take care of it, and if he's still working as a dental hygienist, he's going to be back after 6 months. But it wasn't back after 6 months. So what are we doing? So we're electrical bodies. We're releasing the body's own natural neurohormones, brain chemicals, the endorphin levels, and enkephalin, dynorphin, the body's own natural way of healing. No modality around. The trigger point therapy and all of the modalities that we can use can't hold a candle to what we can do with auricular therapy. Dr. A.E. Solo, that did the work with Janet Travell on trigger point work. I met him in 1973 in St. Francis. I said, what are you doing here? This is an acupuncture meeting. I know I've been doing what you're doing since 1969. I said, well, you're 2 years ahead of me. I presented some of your work, auricular point therapy in Germany in 1973. I was already more excited what auricular therapy could do for that patient than what we were doing with auricular point therapy. Not that it wasn't good, it works every bit as it used to work, but it's you just treat many times symptoms, and you'd have to treat several treatments to notice very much of anything. And with auricular therapy, sometimes 1 or 2 treatments. That's why some doctors say, I can't afford it, it works too well. Then must learn enough about it to slip off at the right points once in a while if you need to have that 2nd or 3rd visit. But many of your conditions, you won't notice a change at all in the first visit. But you treat the right points, the patient notices a change 3 and 4 hours later into the evening. So many times the doctor thinks they've totally failed, where the patient thinks the doctor has totally succeeded. So sometimes, unless the patient reports back to you, you don't know that. So many times it takes treatment plus time. You're not going to get them all in the first treatment, and you're going to have blockages, laterality situations or toxicity with amalgam maybe, and some it's very controversial, as you all know. But also blockages such as scar tissue where you have a toxic scar that might be blocking your treatment. Many times you've treated the patient and had not had success. Go to that scar on the body, or I've gone to it, and also we have scars where you can go to it in the ear and treat the scar. Oh, now my pain is leaving, my pain's gone. So you've already treated the condition, now you treat the scar and it leaves, and you don't even need, many times, even the 2nd treatment. So that's why we inject the scars, and we put the electrodes right adjacent to the scar, moving them in. That's where we use the monopolar electrodes. And tinnitus is where you also use the monopolar electrodes, going into the auditory meatus with saline and going through all frequency ranges, pulling the current right through the inner ear. And you have enough voltage, it goes on up to 100 plus volts, that no matter whether you're on the scar on the body or in the auditory meatus for tinnitus or whatever point you're treating, it's going to flow on that point, and you're balancing that point right at the point. You're not contaminating your therapy by pulling the electrode, by pulling the current from the point down to an anode that the patient holds. That is only in the circuit, in the detect mode, in the detect is how it is. So a clean, dry ear with your probe very perpendicular on the skin surface, and a very slow movement with it clean and dry, and the skin very tight. So you're going to use back pressure. Like this is a TM joint right in here. You're going to use back pressure and move that probe. That's about 10 times too fast. This is just, if you hardly see it moving, that's about the right movement. So, and when the needle moves down, if you know you haven't moved it and it comes up, why, you can still go ahead and treat the point. You have a good day, and let us hear from you. Electrotherapy.com in Tulsa, Oklahoma. Our telephone number is 918-663-0297. Our fax number is 918-663-0298. My email is jim@electrotherapy.com or info@electrotherapy.com. And let us hear from you, and we'll keep in touch. And send that form in relative to your suggestions with our workshops nationwide, wherever you might be, and we'll help support you.